Over the past two sketches, we've covered virtually everything you'll need to know about chronic heart failure. But as you're probably aware, that's not the whole story. In this sketch, we'll talk about what happens when a patient's heart failure symptoms acutely worsen, a state known as acute decompensated heart failure. This sketch builds heavily on the knowledge of the presentation and management of chronic heart failure. So make sure you understand the previous two sketches in this chapter before diving into this one. Anywho, as any self respecting third entry in a non linear movie trilogy would do, we're going to tie the two previous stories you've seen together in a neat little bow. Canon, son. Remember our riverboat wedding from last time? Well, trouble has befallen our dashing prince. It's a shipwreck on the high. River? Estuary? Whatever. The boat is sinking. Who else is there to save him but our mermaid princess from part one? Aw, it looks like this story might have a happy ending after all. What? I like happy endings. They make me warm and fuzzy inside. Anyways, let's dive into our discussion of acute decompensated heart failure. As we introduced in our previous sketches, heart failure, represented by our recurring sketchy floppy heart balloon, is a clinical syndrome resulting from impaired squeezing or filling of the heart. Usually, heart failure is a chronic process that develops over time. Acute decompensated heart failure, then, is when these chronic signs and symptoms quickly worsen, leading to a visit to the ED and often inpatient stay. At Sketchy, our recurring symbol for acute decompensation of any disease is the flare gun, being fired by the mermaid to call for help. Didn't know they had flare guns under the sea. Because most patients with acute decompensated heart failure have already been diagnosed with chronic heart failure, you'll often hear the term heart failure exacerbation used to describe these patients on the inpatient wards. Yep, that means it's likely that your first encounter with heart failure on your medicine rotation will be acute decompensated heart failure. Let's head down to the ED together to perform an H&P on your first heart failure exacerbation patient. Acute decompensated heart failure can manifest in a myriad of ways, just like chronic heart failure. Still, the most common presentation you'll see is acute dyspnea, acute worsening of dyspnea, to be exact. Patients with pre existing heart failure will typically complain of symptoms with less exertion than before, or even have symptoms at rest. At Sketchy, dyspnea is represented by that puff of air, being blown out of the mermaid's cheeks. Hey, you try pulling a human to shore with no legs. In addition to dyspnea, symptoms of peripheral fluid congestion, such as abdominal fullness and ankle swelling, represented by those wet, floppy pant legs on our prints, are also commonly seen in acute decompensated heart failure. Sensing a pattern yet? Any clinical manifestation of chronic heart failure can also be a presenting symptom of acute decompensated heart failure. This includes orthopnea, cough, and wheezing, among others. Appropriate management of acute decompensated heart failure requires identification of its causes and precipitating factors. Let's go over a few of the most common ones now. In close to half of the patients you'll interview, non adherence to chronic heart failure therapy is to blame for their exacerbation. Here at Sketchy, if the home med bag is our recurring symbol for medications, then this torn home med bag with pill bottles spilling out of it should represent non adherence to home meds. Whether they forgot to take their daily meds or just couldn't pass up that supersized order of fries, all patients presenting with known heart failure should be asked about their treatment regimen and, more importantly, whether they've actually been sticking to it. After non adherence, the next most common precipitant of acute decompensated heart failure is myocardial ischemia, represented by that broken heart shaped guitar. Makes sense, don't it? If your heart's already struggling to keep up, an MI isn't exactly going to make things better. Whoa, the evil octopus witch is here? No wonder this whole situation is a flaming mess. In any case, see those red laces on our corset? That's a recurring sketchy symbol for pulmonary hypertension. Any disease that increases pressure in the pulmonary vasculature is not going to be good for someone who's already in heart failure. One important precipitant of acute decompensated heart failure that falls into this category is pulmonary embolism. In addition to causing acute dyspnea on its own, PE can definitely exacerbate heart failure symptoms. It's a life threatening condition that should be ruled out right away. For more details on the clinical presentation and diagnosis of PE, check out our sketch dedicated to it in the pulmonology unit. Severe uncontrolled hypertension is another common precipitant of acute decompensated heart failure. Hence our recurring sketchy symbol for hypertension, the steam coming out of the witch's ears. Look for a patient who's been non compliant with their antihypertensive meds for a long time. That'd make me mad too, evil witch. I getcha. A less common cause of acute decompensated heart failure is renal failure, represented by these rusty, broken kidney shaped pulleys on the riverboat. Whether it's acute or just progression of chronic kidney disease, failing kidneys are less able to remove fluid from the body, pushing someone with chronic heart failure over the edge into an exacerbation. We've mentioned medication non adherence as a precipitant of acute decompensated heart failure, but you should also make sure to get a comprehensive list of home meds your patient is taking. Check out all this random luggage washing ashore from the riverboat. There are recurring sketchy symbols for the cardiodepressant and cardiotoxic drugs you should ask about in your medication history. Drugs such as beta blockers, represented by that muted beta bugle, calcium channel blockers, represented by the broken calcium ice cream machine, NSAIDs, symbolized by that old school 1920s fire extinguisher, doxorubicin, represented by the open box of rubies, and trastuzumab, symbolized by the rolled up tapestry, can all exert direct effects on the heart, precipitating acute decompensated heart failure in certain at risk patients. There are a bunch of other precipitants of acute decompensated heart failure, including systemic infections, arrhythmias, and myocarditis. But the ones we've talked about are the big ones that you'll need to know. In short, virtually anything that stresses the heart can put a patient with chronic heart failure over the edge into an exacerbation. All right, let's move on to the objective findings you should look for during your H&P. First things first, turn your attention to the patient's vitals. The pulse ox is a good place to start, which is why this lighthouse looks suspiciously like a pulse ox clip. Many patients with acute decompensated heart failure will have an O2 sat less than 90% on room air, reflective of the physiologic intrapulmonary shunt that develops from cardiogenic pulmonary edema. Don't know what a physiologic shunt is? Check out our hypoxemia DDX sketch to learn all about it. The blood pressure. You might well expect most patients with acute decompensated heart failure to present with hypotension, but that's not the case. More often, patients are actually hypertensive, especially those with a history of poorly controlled hypertension. It's rare for patients with acute decompensated heart failure to present with hypotension. However, if your patient's blood pressure is as droopy as the sagging red pipe on this ship, with systolics below 90, watch out. Hypotension is a marker of severe decompensated heart failure and can signal cardiogenic shock, which is no bueno. At Sketchy, shock is represented by our recurring symbol, the lightning bolt. That cracked heart shaped spotlight next to it is a reminder that acute decompensated heart failure causes cardiogenic shock. Patients who present in cardiogenic shock need immediate intervention, which we'll get to in a minute. The most common physical exam finding of acute decompensated heart failure is fluid overload. This can manifest in a number of ways, but perhaps the most specific sign of fluid congestion is elevated jugular venous pressure, represented by those blue jug like buoys bobbing up and down in the river. Bilateral lower extremity edema is frequently evident, particularly in the pretibial and ankle regions in ambulatory patients. Next up on our exam, the lungs. Pulmonary fluid overload is another common exam finding in patients with acute decompensated heart failure. Pulmonary edema can manifest as diffuse crackles, typically at the bases, represented by the crackly Velcro on the survivor's white life vest, and even wheezing, a feature known as cardiac asthma, and represented by our recurring sketchy symbol, the loud party blower. While you've got the stethoscope on the patient, take a listen to the heart. The presence of an S3 gallop, represented by our recurring sketchy symbol, the S3 slushy cup, is very specific for heart failure, whether chronic or acute. The best place to listen for an S3 gallop is at the apex with the bell of your stethoscope. Acute decompensated heart failure is a clinical diagnosis, which means by the end of your history and physical exam, you should be pretty confident in your diagnosis. However, not every patient reads the textbook. For those less than slam dunk worthy patients, we can deploy our entire arsenal of diagnostic tests to help confirm or rule out an exacerbation of heart failure. Labs can be helpful in identifying some of the underlying factors precipitating the exacerbation, but they're generally not needed to make the diagnosis of acute decompensated heart failure. Long story short, don't wait for labs to come back before starting treatment. If you are unsure about the diagnosis of heart failure, the one lab that's most likely to help is the BNP, represented by our recurring sketchy BNP blimp. Most patients with symptomatic heart failure have plasma BNP values above 400 picograms per milliliter. That said, BNP results must be interpreted with caution. Use it to help confirm your clinical suspicions rather than making the diagnosis for you. Just like with labs, a chest x ray isn't necessary to make the diagnosis of acute decompensated heart failure, but it doesn't hurt. And like in chronic heart failure, a chest x ray of a patient presenting with heart failure exacerbation can reveal signs of pulmonary congestion, including bilateral pleural effusions, pulmonary edema, and curly B lines. However, don't fall into the trap of blindly following the chest x ray. Up to 20% of patients with acute decompensated heart failure may have normal chest x rays. Check out part 1 of this series for more details on the radiographic findings to expect in heart failure. A 12 lead ECG should be performed as soon as you make the diagnosis of acute decompensated heart failure. The ECG, represented by that grid like fishing net, can reveal important precipitants of heart failure exacerbations, such as acute coronary syndromes or arrhythmias, that should be treated right away. Last but not least, order an echocardiogram. An echo, represented by our recurring sketchy symbol, the heart shaped megaphone, is recommended for most patients presenting with acute decompensated heart failure. In particular, echoes are critical for those with severe presentations like cardiogenic shock, as it can provide a more precise picture of left and right ventricular function. Echoes can also identify certain precipitating factors, such as valvular disease or pulmonary hypertension. Before we move on to the assessment and plan, let's take a look at how acute decompensated heart failure differs from other causes of acute dyspnea. If you've been following along, we've actually mentioned a number of conditions you should keep on your differential in a patient presenting with suspected heart failure exacerbation. Many cardiac conditions that can cause acute dyspnea on their own, such as acute coronary syndrome, arrhythmias, tamponade, and valvular heart disease, are also precipitants of acute decompensated heart failure. These conditions can be sussed out using the test we discussed earlier. The other big category of diseases that can present with acute dyspnea are pulmonary disorders. When it comes to pulmonary disorders, acute exacerbations of obstructive lung disease, such as COPD and asthma, are common mimickers of acute decompensated heart failure. That said, the history and exam findings in obstructive lung disease are often quite different from those of acute decompensated heart failure. In addition, severe COPD and asthma can be differentiated from heart failure by taking a look at the PaCO2 on an ABG. CO2 retention is a marker of obstructive lung disease exacerbation and not acute decompensated heart failure. For other lung diseases, a chest x ray is your best bet. It can quickly differentiate acute decompensated heart failure, which would manifest as pulmonary edema, and more focal lesions such as pneumonia, lung cancer, or pneumothorax. Finally, upper airway obstruction can cause acute dyspnea. However, it's generally pretty straightforward to differentiate conditions like foreign body aspiration and anaphylaxis from heart failure. Listen for inspiratory stridor, the telltale sign of upper airway obstruction, to point you towards the upper airway and away from the heart. Alright, let's summarize the typical presentation of acute decompensated heart failure in a sample assessment statement. Prince Eric is a 57-year-old man with a history of hypertension presenting with dyspnea for the past 5 days that has worsened over the past 24 hours. His medical history is notable for noncompliance with his antihypertensive therapy. Physical exam is notable for a BP of 145 over 95, elevated JVP, bibasilar inspiratory crackles, and an S3 gallop. Chest x-ray is significant for bilateral pulmonary edema. Other studies, including ECG, are unremarkable. Eric's constellation of symptoms and exam findings suggest acute decompensated heart failure, likely secondary to chronic uncontrolled hypertension. Great! You've made the diagnosis of acute decompensated heart failure. Once the diagnosis is confirmed, it's time to quickly pivot to management. Don't worry, the plan won't be nearly as long as it was in chronic heart failure. Acute decompensated heart failure is treated very differently, and fortunately, in a pretty straightforward fashion. The first step in the management of acute decompensated heart failure is to understand which type of exacerbation your patient has. Let's head to the doc. Clinical presentations of acute decompensated heart failure can be categorized according to the patient's perfusion status, aka warm versus cold, and the presence of fluid congestion, aka wet versus dry. The vast majority of your patients will present with the warm and wet clinical profile, meaning they have adequate peripheral perfusion and are fluid overloaded. Hence this first mural of a warm sun and wet rain clouds. After that, the next most common presentation is the cold and wet profile. These are your patients who have hypotension or frank cardiogenic shock from their acute decompensated heart failure. They need treatment right away. These two presentation types comprise more than 90% of all patients with acute decompensated heart failure. The other two dry, that is, not fluid overloaded, presentations are super rare, so we won't talk about their management in this sketch. Whether your patient is warm or cold, two interventions are important regardless of perfusion status. The first one is oxygen. Many patients in acute decompensated heart failure have significant pulmonary edema, which leads to hypoxemia and contributes to their dyspnea. Supplemental oxygen, represented by this deep sea diver holding his O2 tank, should be given to maintain an O2 sat above 90%, which can be easier said than done depending on the extent of the pulmonary edema, since it's an example of a physiologic intrapulmonary shunt. Have no idea what I'm talking about? Neither do I. But we can both head on over to our hypoxemia DDX sketch to learn more about the pathophysiology and management of hypoxemia. Once your patient's ABCs have been stabilized, the next step is to address the wet, aka your patient's fluid congestion. In acute decompensated heart failure, the therapy of choice for fluid congestion is the same: a loop diuretic, such as furosemide, represented by the loop-de-loop of that roller coaster in the background. If your wet patient is cold, that is, hypotensive or in frank cardiogenic shock, take caution. Loop diuretics can lower blood pressure, which is no bueno in a cold patient who's already hypotensive. Likewise, the third component of the initial management of acute decompensated heart failure also depends on whether your patient is warm or cold. If your patient is warm and wet, IV venodilators such as nitroglycerin, nitroprusside, or nasiratide may be added to help relieve dyspnea. At Sketchy, venodilators are represented by our recurring symbol, the dilated blue pants being worn by that sailor. Dude, where's your sense of duty? Jump in and help out, you loiterer. Since venodilators also rapidly lower blood pressure, you must make sure that your patient isn't already hypotensive before giving these medications. Patients who are cold and wet, on the other hand, require action to increase their blood pressure. Inotropic therapy, represented by our recurring sketchy symbol, the buff guy flexing his biceps, is the play here. IV dobutamine, dopamine, or milrinone are used to treat hypotension in patients with acute decompensated heart failure who have evidence of reduced ejection fraction. Speaking of which, if your patient requires inotropic support, it's probably a good idea to discontinue any beta blockers they may be taking, since decreased beta adrenergic tone sure isn't going to help the heart pump any better. You've probably noticed that all the medications we've mentioned so far have an IV form. That's not an accident. IV medications are preferred, or used exclusively, in the initial management of acute decompensated heart failure because of their fast onset of action. That's why we've drawn in this IV, our recurring sketchy symbol for IV, running up alongside of this dock. Once you've stabilized and gotten your patient on the path to recovery, the next step is to determine what precipitated the exacerbation and treat it. Then, after the acute exacerbation has been adequately treated, don't be in a rush and shove your patient out the door, or else they might come bouncing right back. Patients should be placed on an optimal regimen of chronic oral heart failure medications, receive effective education on heart failure management at home, and be followed up within 2 weeks of discharge to help ensure they don't become frequent flyers at the hospital. Alright, let's wrap up this sketch with a brief summary of what we've learned. Acute decompensated heart failure is when the symptoms or signs of chronic heart failure quickly worsen, leading to an ED visit and often an inpatient hospital stay. Any clinical manifestation of chronic heart failure can also be a presenting symptom of acute decompensated heart failure, including dyspnea, orthopnea, peripheral edema, coughing, and wheezing. Acute decompensated heart failure doesn't just magically happen on its own, though. Most of the time, another condition precipitates an acute heart failure exacerbation. In patients with pre existing heart failure, the most common precipitant is non adherence to heart failure therapy. Other precipitants include myocardial ischemia, pulmonary hypertension, uncontrolled hypertension, renal failure, and cardiodepressant or cardiotoxic medications. Regardless of what might have precipitated the exacerbation, many patients with acute decompensated heart failure develop hypoxemia due to fluid congestion in the lungs. While most patients with heart failure exacerbations will have normal or high blood pressure, an important minority of patients will present with hypotension or in frank cardiogenic shock. These patients need therapy right away. The important physical exam findings to know in a heart failure exacerbation are exactly the ones you'd be looking for in chronic heart failure: elevated JVP, pretibial edema, lung crackles, wheezing, and an S3 gallop. Other tests, such as the BNP, chest x ray, ECG, and echo, are supplemental and should be used to confirm your clinical suspicions or look for the precipitating cause. Your first step in the management of acute decompensated heart failure is to figure out which type of exacerbation they have. The clinical presentations of acute decompensated heart failure can be categorized according to the patient's perfusion status, aka warm versus cold, and the presence of fluid overload, aka wet versus dry. All patients can benefit from supplemental oxygen therapy to get their O2 sats above 90%. Wet patients with fluid congestion will benefit from IV loop diuretics. However, be careful with wet hypotensive patients, since fluid removal can precipitate a dangerous drop in blood pressure. In warm and wet patients, consider adding IV venodilators such as nitroglycerin, nitroprusside, or nasiratide to improve symptoms. Once again, make sure they are not hypotensive since these medications will definitely drop their BP. In cold and wet patients, do the opposite. IV vasopressors, like dobutamine, should be given to bump up blood pressure and improve perfusion. Woohoo! You're all done with heart failure. The rest of this chapter will focus on other conditions that make the heart go blah. First up on the list, cardiomyopathy.